Hi everyone, welcome to the fourth Health Technology Standards Seminar Series. My name is Linda Bird. Most of you have met me before, but for those who haven't, I'm an adjunct assistant professor here at the University of Victoria, an active implementer of health interoperability standards, and the instructor of UVic's HIMP 597 course, which is hosting this HTIS Seminar Series. And by the way, HIMP 597 is the field project in health informatics. Before we get started, we'd first like to acknowledge and respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasanich peoples whose historical relationships with the land continue to this day. So, as I said, we're on the fourth seminar in the Health Technology Standards Seminar Series, and we're very lucky to have Derek Ritz with us today, who I've known for a very long time. Derek seems to pop up in countries all over the world, but now he's back home in Canada. And today, Derek will be talking about computable care guidelines. And then next week, he'll be presenting on the Buildable Digital Health Blueprint Toolkit. Just a quick reminder, if you're interested in enrolling in our September intake for the Certificate in Health Technology and Interoperability Standards, applications close soon on July 15th. This is a one-year part-time program with 4 graduate level courses, including this one, which are done through weekly online evening classes plus a virtual workshop. This is the only terminology standards program in Canada that's accredited with CHIMA, the Canadian College of Health Information Management, to become a certified terminology standards specialist in Canada. To find out more, quickly scan the QR code or visit the school's website and look for the certificates page. And so today it's my great pleasure to introduce you to Derek Ritz from the EC Group. Derek Ritz is the principal consultant at EC Group Incorporated, which is a Canadian professional services firm that provides expert advisory services to domestic and international public and private sector clients regarding digital health strategy, architecture, standards, implementation, and adoption. So with that, I will pass the floor over to you, Derek, for your presentation. Thank you so much.
Thank you, Linda, for that kind introduction, and hello, everybody. And just bear with me for a second. I am going to start sharing my screen. And just let me know whether I've succeeded.
You have. We can see it. Thanks.
Terrific. All right. I'm just going to open a couple of things so that so if you put something in the chat, I'll see it, or I theoretically will see it if I'm paying attention. Linda, please, if you see that there's something in the chat that I haven't responded to, please interrupt me. I'm not precious about wanting to sort of get end to end before I take questions. I would welcome having questions along the way. And in fact, I've added little Q&A slides to help me do that. My topic is computable care guidelines. I want to talk about what they are, how they work, and why we should care about them. And I am admitting here with this front slide that this is a bit of a Franken lecture because I'm using content that I have presented before and turning it into one presentation. So here begin my mandatory Canadian apologies. I'm speaking with some fellow Canadians, you know, that's just how we roll. So there it is. I'm sorry, but there's not very much material in here that's fresh. Having said that, I'm a co-lead on the IHE CCG profile. I'll describe a little bit more about what that is. What that means is that this is a little bit my day job. And so insofar as I'm leveraging previous material, it's not so fresh, but that previous material is from only a few weeks ago, and it was pretty fresh then. So there you go. It's a bit of an apology, not apology. This is the presentation I was leading just a few weeks ago, an update on the Gemini project. The Computable Care Guidelines Initiative, or CCG initiative, is what's called a Gemini project. It's a partnership project between two standards organizations, HL7 and IHE. And I am the IHE Gemini twin. My HL7 counterpart is the very clever Bryn Rhodes, who's with Smile Digital Health here in Toronto, actually. The arc of this is, or this is from that presentation, the story arc for that presentation was as you see it. I will give a really quick introduction. I'll talk about what are CCGs and why do we need them, who's made progress and what can we learn, where are we now with it? Now I'm not going to do that part. Then I'm going to skip that and take some content from a presentation I did for the Ministry of Health in the Netherlands a few months back and talk about how CCGs work. I don't know if any of you are leaning a little bit on the geeky side, but I thought it might be interesting for you to see not only the black box description of why CCGs have a value proposition, but the clear box description of how do you make it go, how they do what they do. This is the introduction slide. I live half the time in Toronto. I've just returned to Toronto last Friday from my other home, which is in Paris, France, and I go back and forth between the two. I am involved in some projects in the EU. They have just adopted an EU-wide legislation related to digital health called EHDS, the European Health Data Space. It's very far-reaching, very interesting, and that's not the topic that I'm going to talk about today. I've done work domestically here in Canada on the front channel and the back channel on 6 of the 10 provincial projects. I was in 2007 the inaugural vice chair of the Standards Collaborative Working Group on Infrastructure and Architecture. That's a mouthful. But I've done all kinds of work domestically as an advisor to Canada Health Infoway and sometimes to provincial projects. I've got a geeky side. I'm a recovering engineer. I'm in a 12-step program and coming along well, I'm happy to say. I've been a delegate of Canada to ISO, the Technical Committee for Health Informatics, TC215, since 2008 or so. I've been a longtime HL7 member, Fire Foundation founder, and for 5 years, I was Canada's liaison to the IT International Board and have been with that standards organization a technical committee co-chair and the primary author on a number of their specifications. And IHE is a standards organization that publishes implementation guides, interoperability specifications. But there's a lot of white space here. Since about 2010, most of the work that I've done, not all of it, but most of it, is on behalf of the people in the top third of that collection of pictures, for the countries that are in the rest of the sections there. So I've done work in sub-Saharan Africa, in the Middle East, in the Asia Pacific region as an advisor to the Asian Development Bank, to the US government's PEPFAR program. That's a $7 billion a year program in 53 low and middle income countries. I've worked for WHO. I was seconded to WHO during COVID, and this has already gone on long enough. So I'm gonna carry on. I really want you to take to heart from this. This is for me a disclosure of my biases. Linda and I have had a chance to work together with the Asia eHealth Information Network, for example. And I've done a lot of work in low and middle income countries, and it has changed my perspective. And I think you'll start to be able to note that as I go through my presentation. I really do see things differently, having worked for a little over a dozen years in countries that aren't in the OECD. It makes me see Canada differently. So I'll welcome questions if you have any about what some of those differences might be. All right, let's get into this. What are computable care guidelines, or CCGs? So here's the theory of change here. We want to maximize the care that's delivered in the green zone. So where's the green zone, you might ask? Well, let's assume that the blue circle represents everything that should be done during a care encounter. The green zone is the overlap between everything that was done, the yellow circle, and everything that should have been done, the blue circle. And so we can see from this kind of Venn diagram metaphor that you can find errors of commission, and clinicians don't commit those very often, to be honest, and errors of omission. And as this diagram a little bit illustrates, errors of omission outpace errors of commission by an order of magnitude at least. I had an opportunity for the ISO Technical Committee, to be the primary author of a patient safety and quality of care paper that was done as an internal working paper for the ISO committee. 2009, I think, was when we published that. Lori Fricette and I worked on that together. So the deal for computable care guidelines is CCGs give us a way to define the blue circle, to say what should happen in a way that a computer can understand it. And given the ability to do that, we can now leverage our investments in digital health to systemically push that yellow circle so that we have a larger overlap to maximize the amount of care delivered in the green zone. So, put another way, CCGs afford us a way to operationalize feed-forward process control. Remember when I said I was a recovering engineer? I'm not a fully recovered engineer. So some of you who haven't had to suffer through engineering school are probably saying, feed what now? Here, let's go through just briefly a little sidebar on how digital health impacts on health. So this is pretty not controversial. Health interventions yield population health. When we do things like give HbA1c tests to diabetics, or we give a course of vaccines to babies, those health interventions have a big impact on population health. Now, this is a little more controversial than the first statement. Digital health infrastructure operationalizes health interventions. On the face of it, that's pretty obvious. But in fact, I differ from some of my health informatics colleagues. I don't think that digital health is a health intervention. I think digital health is an industrial engineering intervention. Digital health's role is to help us be better at the health interventions, to help us be more consistent in applying those health interventions, to help address equity challenges in the application of those health interventions. So digital health actually is an industrial engineering intervention. And when we leverage standards-based digital health solutions, we can we generate data, but that data is in a computable format. I can only imagine how many times you will have heard from Linda that if we don't code the data properly, it isn't going to give us the kind of value that we otherwise need from that data. So when we leverage standards, we generate person-centric transactional data that we can use, that we can process. We can now generate population level health metrics from these data. We can aggregate the data at the person level. Well, that by definition is a longitudinal health record for that subject of care. We can aggregate the data at the provider level and start to support performance-based financing. We can aggregate at the facility level or at the regional level and start to do health system management. We can aggregate at the national level, and that gives us the indicators that we report every year to WHO. So this is starting to show how we set ourselves up with our digital health investments to start to operationalize a learning health system, because these metrics can inform not only how we do a better job in our health interventions, but can start to inform the health interventions themselves. It was from big data analytics that we informed a change to the HIV care guidelines because of what we learned in leveraging antiretroviral medicines at scale in sub-Saharan Africa. And so our data informed a change in the course of care for HIV. So, I do I get to ask questions, Linda? I'm sorry, looking this way because that's where I see you guys. Can I
Yeah.
ask questions? Okay, well then I have a question for the team. Anybody? What have I highlighted in yellow? What would you call that? These arrows pointing back. Listen to me
The
giving you
feedback
hints.
system?
There you have it. And the gummy bears go to Debbie. These
Yay.
arrows, in fact, are illustrating feedback. And that's because we're taking information that we have subsequent to our care delivery efforts, and we're leveraging these to feed back into improving those efforts. It's the very heart of continuous quality improvement. I don't know if as many people know that feed forward is when you make an intervention without having waited for the impact on the system to be measured. So in fact, we can leverage digital health when we're operationalizing best practices. We're doing feed forward process control. When I've had to teach process control, I use the bathtub analogy. If you've got your hand in the tub and you're adjusting the faucet, that's feedback because the water from the faucet has already had its impact on the system, the tub being the system. Everybody who's ever had to bathe a baby knows that you use feed forward process control. You put your hand in the stream to make sure that the water's not too hot before it goes into the tub where the baby is. So feedback is when you've got your hand in the tub and you're adjusting the faucet. Feed forward is when you have your hand in the stream and you're adjusting the faucet. Think about what I said before. CCGs give us a way to operationalize feed forward process control. We can systemically narrow what WHO calls the no-do gap, that sometimes wide chasm between knowledge and practice. Now, there are some super cool implications for AI here, because if we play with our Venn diagram a little bit, what if there are some non-indicated care activities that are systemically yielding better health outcomes? If we've metered the system with our digital health, there might be a whole cohort of clinicians that have just read the latest edition of the New England Journal of Medicine and are trying something that actually isn't what's indicated in the care guidelines for diabetes care, or hypertension care, or what have you. And what if their activities that aren't part of the big blue circle are yielding systemically better outcomes? Or what if not doing something that is indicated yields either the same or even better health outcomes? This is actually a fantastic use of big data analytics and AI-based machine learning, because you're working on these large data sets, and machine learning absolutely rocks when it's got a mountain of data to chew on. I am a much bigger fan of leveraging machine learning to find things like this than I am of the idea that machine learning is going to be, that the AI is going to be my new doctor, that on a person-centric basis, I'll be so consistent with the training data set that they can make recommendations about me. I will, for probably a very long time, prefer that humans are doing that. But this is a terrific use of AI as an example. What are some key takeaways here? We can leverage digital health to both meter the system and to exert process control upon it. Digital health is playing an industrial engineering role when we're doing that. It can be leveraged to improve consistency in the execution of the health production function. If you have a baby food manufacturing facility, you're in the baby food production function. But if you run a Ministry of Health, you're in the health production function. And when we leverage digital health this way, that's feed forward process control. I believe very strongly we should leverage digital health in support of care. I like that that gives us atomic person-centric data, because that serves both care and the population level monitoring. I'm not a fan of leveraging digital health to just collect indicators. And I know that's not especially common in Canada, but trust me when I tell you, I've been doing the John the Baptist thing for almost 15 years now, that donors should not be supporting digital health just to collect statistics in low and middle income countries. They should be leveraging digital health investments to improve the care workflows. My grandparents on my mom's side were Saskatchewan farmers, and my grandfather used to say, "You will not have more chickens by counting them more carefully." I don't think you can statistics your way to a better healthcare system. At some point in time, you have to start doing a better job of the core business, which is care delivery. Now, analytics can be leveraged and should be leveraged to do to support continuous quality improvement in the health system operations. or in improving the interventions themselves. And that feedback loop that Debbie identified for us, that feedback loop creates a learning health system, or that's what it's been coined, the learning health system, by the National Institutes of Health in the United States. And everybody else loves it too, so that's what we all call it now. I'm going to pause here for just a second. Are there any questions?
Did you say that it's the unpopular opinion that, because I agree with you, and so I'm just really surprised.
Which unpopular opinion? Sorry.
So the last thing that you had said, sorry, was that about using the data, right? Like, are you digitizing data to capture information versus?
So one of the things that Linda and I have both found ourselves witnessing in many low and middle income countries, there's a lot of investments in health management information systems. So there is an open source platform, which frankly, I love this platform. I love the people that work on it and that implement it. And it has been helpful. It's called DHIS2, the District Health Information System version 2. And it has been implemented all over the world, 80 countries maybe. But its job is not to support care delivery. Its job is to collect statistics. It's the digital equivalent of tally sheets, where the tally sheets were big paper logs, and if you were running an antenatal care clinic, you would just literally count the number of women that you saw that day, and you'd report how many pregnant moms you saw every day. A tally sheet. I don't like that there's been such an uptake and such a huge investment. The Global Fund poured money into implementations of DHIS2 all over the world, and they more precisely measure just how dysfunctional those care delivery networks are, but do nothing to improve them. And when I say I've been, doing the John the Baptist thing, I was ballyhooing in the wilderness for a very long time before this idea that the digital health should be applied at the point of care started to take hold. Trust me when I tell you, in low and middle income countries, that can be challenging. You don't always have the electricity on, and the network might not be up all the time. There's a lot of things we take for granted in Canada that aren't true everywhere. But I do think that, and I do know that we were able to ride a wave that we didn't have to make happen. And that's been the uptake of mobile phones in the global south. And those crappy little Nokia candy bar phones that you guys remember from 15 or 20 years ago, no self-respecting Canadian teenager would be caught dead with these uncool phones. We leveraged SMS messaging to reduce maternal mortality in Rwanda and in Ethiopia, and it worked great because those crappy little phones are computers. And SMS messaging is just a kind of low bandwidth UI. But with that UI, you can do all kinds of amazing things if you leverage the digital health at the point of care.
Yeah, that's incredible. Thank you.
I am glad that we agree on this. It makes me feel comfortable that that's the way I feel too. Any other comments or questions? Okay, I started talking about, oh yeah, I was going to talk to you about what are computable care guidelines. So this is take two. Let's see if Derek can stay focused long enough to actually say what a CCG is. So for care guidelines, and this is sort of the best thinking of the US CDC and WHO and others, there's 4 levels of knowledge representation. At level 1, you have the narrative level. Level 2 is semi-structured. Level 3 is the computable level. And in level 4, you've operationalized the computable care guidelines. So looking at this, here's an example. This is, in fact, the WHO's guidelines for HIV care and treatment. This is a narrative document. In fact, this is only one of them. I think there's a family of 2 or 3 of these documents. Each of them is about 200 pages long. They read like a Cochrane analysis. Trust me, if you've got insomnia, this is your cure. So that's level one. That's the narrative documents, and the intended audience is humans, because Lord knows humans, if they can't sleep, need these documents. Oh, and if you don't know how to do HIV care, it's also in there. It's just really challenging to leverage the portfolio of these long, dense documents. That's level one. At level two, and WHO refers to these as digital adaptation kits, you can take the level one content and you can now start to express it formally. By the way, at level two is where you often find that the level one people were not as clear as they thought they were being. But at level two, you can now start to describe workflows using the business process modeling notation, BPMN. You can start to describe care logic using decision modeling notation, DMN. So these now become semi-structured documents. They're still intended for humans, but it's now got some rigor to it. These are CCGs. When you now take and express using HL7 Fire, version 4 is what the current specification is for the CCG, the CPG on Fire implementation guide, you now use plan definitions and activity definitions and CQL, which is clinical quality language expressions to describe this care logic in a format that can be ingested by and operationalized by a computer. And that is level 4. So this is where digital solutions are ingesting these CCGs and running the logic. As I said, I'm kind of my day job is that I'm one of the primary authors on the conformance testable CCG profile that's being published by IHE's Quality Research and Public Health Technical Committee. The scope of that profile is to describe a normative format for the CCG artifacts and to describe the normative behavior of digital solutions that process CCGs. This latter part is very important. Think about the regulatory environment in Canada. A solution that is processing CCGs is the poster child for software that is regulated as a medical device. If your EMR is informing the course of care, it meets the definition of a Class 2 medical device. And the publisher of that EMR would probably have to go through the process of an ISO 13485 audit, which is just ISO 9000 for medical devices. I know that because that's one of my practice areas. I've helped a number of companies, one in New Zealand that you might know, Linda, and then a number of domestic companies that actually all of our Canadian teammates would know. But this is an important distinction. Computable care guidelines operate in a regulated environment in most markets. All right, let's look at an example. Let's pick on HIV because I've been talking about it. So in the HIV care guidelines, they are operationalizing what are known as the 95-95-95 cascade. Before I say what that is, anybody want to take a guess at what the 95-95-95 cascade is? And Linda, you're prevented from blurting it out.
Any ideas? Debbie, Ellen, Justice?
Not a clue.
So the care cascade, it's called the care cascade for the following reason. The notion is, the target is, that to beat HIV as a global epidemic, to beat HIV, we want 95% of the people who are HIV positive to know their status. And of those that know their status, we want 95% of them to be on antiretroviral medicines. And of those that are on antiretroviral medicines, we want 95% of them to be virally suppressed. And we can tell that from their every 6 months viral load lab tests. And so the notion is that we've got this care cascade, but from the point of view of a person, this is their care path. They go to a voluntary confidential counseling and testing clinic, a VCCT clinic, and they find out that they're HIV positive. They're put on antiretrovirals and they stay on them. Loss to follow-up is one of our real challenges in fighting HIV, because if you stay on your meds, you can live a long, productive life as an HIV positive person. You manage it as a chronic disease, really. And when you stay on your meds, you're virally suppressed, which means you can't give it to anybody else. So this is how you win against HIV. You operationalize these 3 steps. You get people tested, you have those results drive orders for medications that people stay on, that they adhere to, and every 6 months you take a blood test and you see that they're virally suppressed. Now, one of the very powerful things about a computable care guideline is if you know what should happen, you can treat the absence of a signal as a signal. If you've been dispensed 2 months of antiretroviral medicines, and it's now been 3 months since those were dispensed to you, and you haven't shown up to renew your prescription, I can treat the thing that didn't happen as an actionable signal because I know it should have happened. It's astoundingly powerful. So the game here is we take our HIV care guidelines, we express them in the FHIR standard as computable guidelines for HIV. In that computable specification, we will define what the minimum data set is for HIV care. We'll define what the workflow logic is. We'll define what reportable indicators are that will naturally and organically arise from the data that we'll collect during care delivery. And now these computable guidelines can be ingested by digital health solutions to operationalize guideline adherent care across the length and breadth of the care delivery network. And it's not just for HIV. If you've got somebody who's in an antenatal care situation and who's also HIV positive, it's not like any one disease program defines you. I'll just leave that there. That's the deal. There may be more than one thing to focus on during a care encounter. And in fact, improving care continuity and care quality, especially for comorbid patients with multiple chronic conditions, is our big and expensive problem in Canada. This is very fresh data. This is from only, I think, a year or 2 ago. 30% of Canadians over 35 suffer 2 or more chronic conditions. This costs our economy upwards of $190 billion every year, and it accounts for almost 60% of our total healthcare spend. And the US is in the same boat as we are, and the Europeans are in the same boat as we are. This idea of a burden of disease to say, oh, we have to fight diabetes. Yes, we do. Oh, we have to fight hypertension. Yes, we do. Oh, we have to fight ischemic heart disease. You bet we do. And those 3 walk hand in hand all the time. It's not like we have to do any one of those things. We have to do all of those things. I've just given some statistics from home. I've told you already, I do most of my work in the 150 countries that aren't in the OECD. And these numbers are a little bit older. This is from 2018 or 2019, I think. But this is staggering. Absolutely staggering. Between 5.7 and 8.4 million deaths occur annually, not because people don't have access to care, because people are killed by the care they're getting, by low quality, poor quality care. And trust me when I tell you, WHO is doubling down on digital health as their way to address this issue. In 2019, the year after this report came out, they established the Department of Digital Health and Innovation, DHI. And one of my very good friends, Linda's too, Alain Lebrec, is the lead of that. I was actually seconded to that department for a year and a little bit during COVID to help lead the charge on the COVID certificates initiative. but this is a big deal. And computable care guidelines speak to addressing this big deal. So here's some key takeaways here. CCGs at scale help care delivery networks maximize the care delivered in the green zone. And to support scale, you want to leverage content that you're going to find shared in the longitudinal health records for whoever it is that is going to be receiving the evidence-based care. Digital health solutions that can ingest and operationalize CCGs are the exact opposite of this siloed app idea. I say that, and you can probably hear the little drips of sarcasm in my voice. I say that because here in Ontario, that was what they did. They doubled down on, oh, we'll have to have an app for hypertension. Oh, we should have an app for diabetes. Oop, let's do another one for heart disease. And I was astounded. I think that that's not what we want. What we want is for the electronic medical record solution that our care providers are using to be able to say for the patient in front of them, oh, look, it's Derek. Derek is being treated for his hypertension and his diabetes. And then Derek will go, and then Linda will come in, and then Linda's being treated for the 1 or 2 or 3 things that Linda's being treated for. And that we shouldn't have this poor clinician going from app to app to app. This siloed apps idea, I'm very not fond of it, as if you couldn't tell. What I also like about the way CCGs work, and we're going to get to that a little bit later, is that a well-formed CCG can be concurrently executed with other well-formed CCGs. And that gives us the opportunity to say, oh, well, here's a pregnant woman who's also HIV positive. So I'll do all of these things during her 3rd antenatal care visit, and it's time to take blood and have a viral load test done. Oh, and it's time to replenish her antiretrovirals, because you're looking after the person. It's person-centric, not disease-centric, person-centric care. I love that. I hope I made the case. This is a problem that's worth solving. All right. I told you that these are everywhere. I'm going to pause again for questions. Does anybody have a comment or a question?
Just to comment, Derek, that this has been a theme from a few presenters and one that I've reinforced for the students, and that's the person-centric care in terms of the journey as well. And hopefully the students have picked that up from my presentations and from others as well. It's just crazy to think, isn't it? And I think it's normally a funding thing. Funding comes for a particular chronic disease, and so that's why these individual disease-focused apps exist. But thank you also for not mentioning the 3 or 4 conditions that I saw the doctor for.
Well, I know you to be healthy, hale and healthy, and I couldn't think of anything that you could possibly be
fabulous. I was on the edge of my seat waiting to hear what I had. But Debbie, Ellen, and Justice, do any of you have any questions for Derek at this stage?
I mean, I have all sorts of comments. I'll talk about this for hours. So, I'm kind of nerdy in this sense too. I think it's really interesting that the WHO, and this might come across very badly, but I'm very intrigued by the WHO's investment in this, because I find that classifications and the whole process of coding, I think, splits apart a lot of these patients and causes these kinds of issues. And so I'm, like looking at your statistics and things like that, I think they're probably quite a bit higher, because I think in some cases, a lot of the information we're getting is from coded data, and coded data, I think a lot of the time is hiding things or excluding information.
So I'm gonna grab onto that a little bit. I don't see WHO as the villain here.
I don't think they're a villain.
Well, no, I mean, I don't think they are at all, because I think that they're doing some really important work, and it's going to matter that they succeed at it. But I do think that there are some villains here. And one of the things, and I don't know if this has been an experience that any of you have had, but if you go into a doctor's visit and they say only one only one complaint per visit.
Yes.
And I'm
Yeah.
thinking, are you kidding me? And the villain here where I live, the villain is OHIP.
Yeah.
The villain is how we pay the clinician, because the clinician
Right.
has to make a living. And to be honest, everybody's behavior is driven by their paycheck. And the only one complaint per visit is based on how they're going to be doing their claim and the adjudication of that claim. And if you
Correct.
want to see me about the other thing, well, come back again tomorrow. And I find that infuriating. Absolutely infuriating, because it's just, we locked, we loaded, and we shot our own foot off. And then we complain. We complain about a care delivery network that's not working for us. And it's just like, well, oh my gosh, this system works exactly as you designed it to work, comma, you idiots. I find it frustrating that our challenges, frankly, are not in terms of clinical care or the technologies that support it. It's in terms of governance, and it's in terms of how we pay, what we pay
Absolutely.
for, and how we pay. And we've
Yeah.
done it to ourselves. And
Yeah.
mercifully, I get to give advice on these topics to some of the ministries that invite me to come and work with them. And I use I use these mistakes where I see them as cautionary tales. There's a number of countries that I've been involved in helping them set up UHC, universal health coverage. And boy, you want to just, the primary cautionary tale, it's interesting to me. The country that funds me to do much of this work, it's often through US funding. World Bank is, the primary funder for Asian Development Bank is Japan. The primary funder for World Bank is America. America, the only country in the OECD that doesn't have universal health coverage, has funded most of the universal health coverage work that I've done. I'm curious from Justice and Ellen, do you have thoughts on this? Nope, it's okay if you don't. I can tell you something, and I mean this to be as encouraging as it sounds. I think that we, as health informatics professionals, have got a really crucial role to play in the re-engineering of our care delivery networks. Not only do we need to be person-centric in our care, we need to be person-centric in how, in terms of what is driving our care delivery networks. And by that, I mean we need to be person-centric, not provider-centric. Our care networks are organized around the provider, not around the patient. It's like you go and you visit where your data is because your provider is the one that has the data. No, the new legislation that came out just some weeks ago, the connected care legislation, means no, my data follows me where I go. And every provider that sees me is part of the arc of my health story. I'm not just something that walked into their office to be part of their story. They are contributing to the arc of my story. And to re-engineer our care delivery networks around that is going to be challenging, and we will have a role to play because our investments in digital health are going to be enablers for that. And it's a big deal. And I need you to take it seriously because I'm retiring soon. So this is a torch passing kind of call to arms thing here. And I'll stop blah, blah, blahing, and I'll carry on with what I'm supposed to be doing, which is giving a presentation. So who's been making progress on scaling computable decision support, and what can we learn from what they've been doing? So I mentioned that I've been involved with the Quality Research and Public Health Technical Committee at IHE. I was one of the primary authors of a 2017 white paper on integrated care pathways, and that's where we were looking at the technologies we had in hand at the time. Keep in mind, this is before FHIR was available to us. We were looking at BPMN and found issues with it, and we surfaced what those issues were. A companion technical committee, the Patient Care Coordination Committee, defined a FHIR-based profile initially in 2016, then updated in 2018 and 2019 around dynamic care planning. And that's where they started to leverage the activity definitions and plan definitions. And in fact, the CCG profile is leveraging that work. And that was launched in 2018 and became a Gemini project the next year with HL7. My Gemini project twin, I think I might have said, Bryn Rhodes, he is the driving force behind the CPG on Fire implementation guide. It's just completed its second ballot. It's based on Fire R4. And IHE's role, my role in that partnership, is to take that underlying standard and the specification for CPG on Fire and to do what needs to be done to simplify it, to take the optionality out so that it can be more readily implemented and so that it can be, importantly, so it can be conformance tested. WHO, since 2019, I actually helped launch this initiative. They have a full head of steam under what they call the SMART Guidelines Initiative. They have these digital adaptation kits. They've worked on an antenatal care kit, an HIV care kit, an immunization digital adaptation kit, and one for IMCI is integrated management of childhood illness. That I knew would come to me. Care for under fives. Interestingly, and I'd be happy to answer questions when it comes to the Q&A slide, WHO does not plan to use the IHE CCG profile, and I can happily tell you why if you're curious about it. The US ONC, the Office of the National Coordinator, has required clinical decision support solutions to be tested in a way that informed how we're approaching the IHE CCG profile. All CDS products in the United States have to be based on the CCDA, which is the Clinical Document Architecture is what CDA, it's the Continuity of Care CDA, the Patient Summary Specification, even further constrained by what's called the IHE Health Story Consolidation. Here's the gist of it. It's a highly profiled data model for person-centric content, and all clinical decision support products have to be able to run off of that content. That's because it's the care continuity patient summary that is mandated in the United States. So if you expect something to be broadly deployed, that's the data you're going to have at hand. The content that is defined there is very similar to the International Patient Summary. That's what IPS stands for. And the IPS is the foundation of our Domestic Patient Summary, PSCA. We're expecting in Canada to leverage that patient summary to drive clinical decision support, to drive care continuity. Denmark has been leveraging a CDA-based patient summary for years to drive their clinical decision support for their top burden of disease, which is COPD, type 2 diabetes, and heart failure. They're in the process of moving to FHIR, and I'm working with a counterpart on one of my EU projects in that work. Gravitate Health is leveraging IPS documents to support clinical decision support around medications. And then countries that in fact, 3 countries I've worked in, Myanmar, Cambodia, and Botswana, are leveraging the International Patient Summary as part of Open HIE on Fire. Open HIE is an open source initiative that leverages, actually, the Canada Health Infoway architecture is the foundation of it, but it is a health enterprise architecture open source initiative. And this HIE is Health Information Exchange. If folks, I'm falling into acronym hell, aren't I? But Open HIE on Fire, and IPS is a key part of that, is the foundation of the health enterprise architecture for Myanmar, Cambodia, Botswana, honestly, about 60 countries. Kenya, Tanzania, Philippines, Indonesia, stop me anytime. Anyways, it goes on and on and on and on. key takeaway points here. HL7 has progressed their CPG on Fire initiative. That is the underlying standard of IHE's work around the Computable Care Guidelines profile. WHO has progressed its SMART guideline effort and has begun publishing digital accelerator kits, and they have, that's the L2 artifact, remember, level 2, and they have one L3 artifact, the antenatal care artifact. Conformance testable implementations in the US, in Denmark, NHS Scotland have all adopted common data models based on the patient summary specs that they work on. In NHS Scotland, for example, all of their CDS stuff is also registered as a Class 2 medical device. NHS Scotland hosts their engine that runs the clinical decision support, and it has been it's gone through the ISO 13485 auditing, and it's a puppy with papers. The concurrent execution of multiple CCGs is a must-have requirement to address. Anybody remember what MCC stands for? Blurt it out. Multiple chronic conditions. If you have to support multiple chronic conditions, when you see Derek, you want guideline-based care to be delivered for Derek's diabetes, for his ischemic heart disease, for his hypertension. It's the Q&A slide. Are there any questions about this so far?
Any questions? Just as mentioned last time, great presentation, no questions from him at the moment. So,
okay. I'm going to speed up a little bit because I want to get through this next bit. This next bit is technical, and if you're technical, you're going to love it. If you're not technical, it's illustrated mostly with cartoons, so I hope it will be digestible for you. And I'll get through it quickly for two reasons. One, I don't want to go over time, and two, I do want to save time at the end for whatever the discussion is that you would most like to have. And I will again give a little Canadian apology. I'm getting over a cold, so my voice might be low and sexy, and I just want you to know that's not what I usually sound like. Okay, this is the, remember I said it was a Franken lecture? This is content from a presentation I gave to the Ministry of Health in the Netherlands last November. So let's look at how it goes. In any, the generic steps for any typical care encounter, I always think of this as like the 1, 2, 3, 4 of a dance step. The 1, 2, 3, 4 is I have to identify the patient. I have to fetch the patient's health story. I want to provide evidence-based care to them. And then I want to update the health story. And you repeat 1, 2, 3, 4, 1, 2, 3, 4 throughout the care delivery network. Every time you see me, this is what you do. Identify which Derek I am, get my story, provide me guideline-based care, update my story. Now, for those of you that are technical, you can just shed a tear of happiness. This is a BPMN diagram. I've even identified the normative transactions, what the normative behavior is of a digital health solution that is going to be CCG capable. This is what it has to be able to do. But honestly, I'm not even going to go into it in a lot of depth because all this is a great big 1, 2, 3, 4. At step 1, you identify the patient. So you do a client registry lookup using HTIS 78. That's the transaction that gets you content about, the demographic information for Derek. If there is no Derek, then you have to enter it. Or if I've got a new mobile phone number, you have to update it. You would do that using ITI 93. Then you have to look up my information. There's a set of transactions that do that, including the specification for the IPS. Then you provide care to me, and then you update my health story and use ITI 65 to do that. You send information about the encounter, date and time of where it was, who was caring for me, where was it, all of that stuff, plus the updated IPS for Derek. We're going to focus on this part, the provide guideline-based care part. So we're going to drill down on that a little bit. Now, looking at the process model, we can actually express the process model for how you process CCGs using, again, a BPMN diagram. This is not intended to be an eye chart, and Linda is going to share the presentation to you afterwards. But keep in mind, the idea here is that there's a bunch of predecessor stuff I have to do. And then at step 4, which is here, I basically go through an iterative process of doing one of, I think, about a dozen things here. And these are the verbs that you can use to express a computable care guideline. And so you can provide counseling to me, record observations about me, order tests for me, conduct tests, record a diagnosis, order interventions, provide those interventions, order meds, dispense and administer the meds, establish monitoring and follow-up to say, see you again in 3 months or whatever, or escalate my care. You can refer me. And that's the palette. Those are the verbs you can use to express the CCG. Well, that's the processing model. Now let's look at the data model. And this is literally just cut and paste from the International Patient Summary FHIR Implementation Guide. And I think these are actually live links, are they? Yeah, they are. So when you get this deck, you can click on any of these. This is the stuff that you can know about me. You'll have information about my meds, my allergies and intolerances, my problem list, my updated immunization history, a history of all the procedures on me, any medical devices I might have, diagnostic lab results or DI results, diagnostic imaging results or pathology results, my vitals, past history, pregnancy status is pretty empty for me, my social history, functional status, my plan of care, and any advanced directives. Now, for CCGs to be superimposable, and they must be superimposable, the metaphor is the key. So, metaphor number 1 is we express a computable care guidelines as a folder full of cards, and CARD is an acronym. So every evidence-based recommendation has a condition. So when this is true, you should take this action. So that's the A in CARD. And if you take that action, you'll have resulting data, CARD. So every evidence-based recommendation goes on a card, and this stack of cards goes inside a folder. And the folder would be, here's the diabetes folder. So the condition for which this CCG is applicable is a diagnosis of diabetes. There could be an antenatal care folder, an HIV folder, a ischemic heart disease folder. And for every one of these, there'll be the set of cards that say, under these conditions, take this action. And if you take that action, here's what you're going to end up with. All of this metaphor maps to plan definitions and activity definitions and CQL libraries or FHIR path statements. That's how the logic gets expressed. That's metaphor number 1. Metaphor number 2 is that there will be an iterative card stack processing model. And if you follow it, you can process multiple CCGs concurrently, and you will process them in an inefficient but patient-safe way. So this is not optimal with regard to processor capabilities. This is optimal with regard to never, ever, ever, ever having a card fall through the cracks. So this is what it's going to look like. If I had an antenatal care folder, the condition would be diagnosis equals currently pregnant. And then there would be multiple cards inside the folder. And one of the cards could be that each of them is a globally unique ID. That's what GUID stands for. So a condition statement there could be if the blood pressure is higher than this target and the pregnant mom is not on blood pressure meds already, then prescribe blood pressure meds. And the resulting data is that there will be a FHIR medication request resource for the blood pressure medications. You could have an HIV folder The condition statement for the folder is that the diagnosis is you're currently HIV positive. And cards there could be, again, it'll have a globally unique ID. The condition, if it's been more than 6 months since your last viral load test, and there's not an active viral load test order already in your summary, then order a viral load test. And the resulting data is that there will be a service request for that lab, for those labs to be done for you. Service request is a FHIR resource. So here's a really quick illustrative example of how that would work. Meet Mosa. Mosa is pregnant. She presents, unfortunately, 4 weeks late for her second antenatal care visit. She was given an HIV test at her first visit, and she is HIV positive. By the way, just so you get a sense of it, I did a lot of work in South Africa, for example. In Eastern Cape Province in South Africa, the prevalence rate of HIV is 1 in 3. Can you imagine walking through the streets of Victoria and every third person was HIV positive? Nope, nope, yup, nope, nope, yup. That's the prevalence rate in Eastern Cape Province of South Africa. So in South Africa, at your first antenatal care visit, you always get an HIV test. So Mosa has been placed on PMTCT, Prevention of Mother-to-Child Transmission Protocol. And part of PMTCT is that she is immediately put on antiretroviral medicines. Now, let's follow through our little cartoon path here. So the first thing that happens is we establish the care context. Where are you? What's the date and time? Who is it that's providing care to Mosa? And we grab Mosa's health data. So we get Mosa's International Patient Summary. I've noted in red the diagnosis of currently pregnant. So that's why the ANC folder will apply to her. HIV positive, so the HIV folder will apply to her. And she was dispensed her antiretrovirals 2 months ago, and she was given a 2-month supply. So that is things that we should note that are actionable at this particular encounter. So there's 2 folders that apply for Mosa. We shake all the cards out of both folders and create a single stack of cards. Then we update the minimum data set. We invoke the $apply operation, which is a normatively defined operation in the FHIR standard, and we get back the CCG recommendations. And it'll be a whole bunch of things that you're supposed to do at every encounter. So at every encounter, provide pregnancy counseling, provide applicable HIV counseling, measure the mom's blood pressure, measure her temperature, measure her weight, measure her heart rate. And if the current date is greater than the last ARV dispense rate, plus whatever the coverage period was, renew her meds. So those are the cards that fired true. We leverage those cards to dynamically build a UI that will collect coded data. This is doing synoptic reporting, which means the UI says, I want to measure the blood pressure in millimeters of mercury. This is the field for the diastolic. This is the field for the systolic. And you can't get it wrong. It's not sort of asking you for free text. It's creating a synoptic form. That's fantastic because from a synoptic form, we collect good coded data. Good coded data is gold. And everything has to be recorded. You either record that you did do what you were supposed to do, or you record that you didn't do it, and you say why. But there's no skip it. There's no not do it. And that's because you have to be explicit and deliberate. You can't treat a blank as you can't have a blank. You either collect the information or you say why you didn't. It's one of those 2 things. Well, now that information that we collected gets fed into an updated patient summary, and then we update that information to the CCG engine, invoke $apply, and get back a new set of recommendations. So Mosa's blood pressure was actually elevated. And we recorded that, and then we sent that updated information into the CCG engine. Pardon me again. Well, that new information caused a new card to fire true. And it's the card that says if the blood pressure is over target and she's not already on blood pressure meds, put her on blood pressure meds. Because treating preeclampsia means you don't get eclampsia. And when you don't get eclampsia, things go much better for the mom and the baby. So now we generate the user interface. By the way, CCGs also help us deal with the cognitive load that providers are under right now. This is not saying, hey, you should go figure out what meds you should order for her. This is just saying, we know what you should order for her. Just click here. It's like the easy button. Just click here and we'll create that order. Or don't, but say why you're not going to. But this is intended to make it easy to do the right thing. And that's a pejorative comment because it means that following the care guideline is the right thing. Trust me when I tell you, adherence to care guidelines has a huge and positive impact. The Veterans Health Administration, the much maligned Veterans Health Administration in the United States, gets the best diabetes results on planet Earth, and it's because they just took all the fun out of it. It's the military. And they just say, if you're caring for a US veteran who's diabetic, this is what you do. Pardon me. So the meds are ordered for MOSA. We put that in. We then do the updated minimum data set. That's what MDS stands for. Invoke the $apply operation. The CCG recommendations come back empty because no card's fired true. So I stay in the loop until there's nothing more that I should do. And now I update MOSA's health record. And in this way, I'm caring for MOSA. I'm not an antenatal care clinic that doesn't care about any of the other things that are true about her, or an HIV clinic that doesn't care about any of the other things that are true for her. I'm caring for MOSA, who is HIV positive and pregnant. I'm helping her in the course of her pregnancy. I'm helping her with her lifelong course of care regarding her HIV. Now, for this to work successfully and correctly, here's some important simplifications. This is where the IHE work has simplified the underlying HL7 specifications. The encounter context has to be established before you start. You have to know the provider, the location, the date and time, all of those things that are in an encounter resource, a fire encounter resource. All of the CCG condition statements have to be defined in terms of the IHE care services discovery profile, which is how you describe information about providers, information about facilities, information about the services that are provided by that provider at those facilities, and so on. So there's a specification for that, and or the IPS. That's where the person-centric data is there. All the condition statements have to rely on those two data models. All of the actions have to be defined in terms of one of the card types. And remember, I said there's 12 different card types. And if you follow the action, whatever it is that you did or that you're supposed to do, if it's an order, has to be expressible in the IPS data model. So if you make a medication order, it has to follow the rules for being persistent in the IPS. If you record the blood pressure, you have to record it in the way that's mandated by the specification of the IPS. So these important simplifications make it work. The key takeaways here A normative behavior for CCG processors gives us a patient-safe way to concurrently execute multiple CCGs. These simplifications enable us to go to scale in regulated markets, because by taking all the fun out of it, by taking all of the flexibility and optionality out of the underlying standard, we now have a conformance testable normative description of what should happen. The IHE CCG profile is for mainstreaming CCGs. So it's tied to the patient summary. It's tied to the data that's going to be following the patient wherever they go in the care network. And that is intentional. It is restrictive. And there's been some people who've said, well, I'm not sure that's expressive enough for me to do oncology modeling of apheresis or something that's pretty arcane. And that might be the case, but you're not mainstreaming that. You can only get apheresis in the academic teaching hospital anyways. It's pretty sophisticated stuff. The IHE CCG profile is for the things that have to happen everywhere, all the time, for all of us. It's for mainstreaming computable care guidelines. And I'm at the end, and I've saved myself almost, actually 15 minutes for questions.